everyone, to today's second webinar coinciding with the release of Humana's 2021 Bold Goal Progress Report. We first launched our Bold Goal in 2015 to improve the health of the people and communities that we serve. We defined health using CDC's health-related quality of life measure called Healthy Days, and we've had a really intentional focus on understanding and addressing social determinants of health in order to improve health outcomes. So today, we're really celebrating accomplishments. First off, statistically significant improvements in Healthy Days. Secondly, scaling up the number of social needs screening. In fact, we did 6 million screenings in 2020. And also celebrating some successful interventions. One example is our basic needs program that delivered over 1 million meals to 80,000 of our members, our most at-risk members during the pandemic. But we're also acknowledging that the impact of the COVID-19 pandemic had on our country, and in particular, how it shined a light on social determinants and social needs. Social needs existed for many people before the pandemic, and the pandemic created new needs for lots of other folks. And the pandemic certainly confirmed that, when it comes to public health, to population health, there isn't a linear path, and there's not really a finish line. So there will always be curveballs, natural disasters, economic hardships, global pandemics. And so as we look to the future, I think we take pride in what we've achieved, but also this is an opportunity to rededicate ourselves to this work, to build partnerships, take action, address these needs. And so that's really what we're going to talk about today, is the future of population health. We're going to cover 3 topics with 3 awesome panelists. Topic 1 is about addressing data, analytics, and technology to understand social needs. And the lead discussant for that one is Dr. Laura Gottlieb, who's the professor of family and community medicine at the University of California in San Francisco. She's also the founding director of the Social Interventions Research and Evaluation Network, which is a mouthful, but we affectionately call it Siren. Topic 2 is how we can address, how we can continue to drive social determinant innovation. And for that, we have a great lead discussant, Rivka Friedman, who's the Group Director, State and Population Health Portfolio at the Center for Medicare and Medicaid Innovation. Thanks, Rivka, for joining us. And our third topic is identifying and addressing health inequities as part of an integrated model of care. And the lead discussant for there is Dr. Wando Alewala, who is Humana's Chief Health Equity Officer and my partner in crime, or should I say partner in health. So welcome to you all. Thanks for joining. This is going to be an awesome, awesome conversation. Laura, I'm going to start with you, if that's okay. Laura, are you on? I can't quite hear you, Laura. I think you might be on mute.
How's that? Good?
Much better.
Can you hear me?
We can indeed. So thanks for joining us. The first topic that we really want to get into, I'm going to focus on you, but I want other folks to join in. It's this idea of data analytics and technology. How can that help us understand and address social needs? So I guess just to kick it off, in your mind, what are the big themes when it comes to social determinant data and analytics?
It's a great question. Let me just start by saying I'm so honored to be part of the panel and to sort of be connecting with your audience. Humana's done so much good work in this field, and then to be on a panel with Rivka and Wando is really, really fun. And I'm super, super jealous that you now call Wando your colleague, because she used to be my colleague. And I can't help but say, wait a minute, what happened? How did that happen? But wow, what a team you have going there. So, okay, so all that said, I'm going to go back to your question. And what are the big themes here? So first I'll just say, our researchers, our data analysts, our technology universe is really racing to catch up with innovation in this space, including innovation from the Bold Goal team. It's a super exciting time to think about what and how to use data and analytics to support our understanding not only of what works, but also how to put what works into practice. So we refer to those as effectiveness research. Do they make a difference on how these kinds of social care integration practices make a difference in health? And then how do you actually put them into place in busy clinical settings? It is a very different question, but data and analytics can help us understand both. So one of the things that is really critical as we build the case here is some consensus about what data and analytics we need. So right now we just don't have a ton of consensus about what information should be collected to tell us, for instance, if a referral was effective. We don't have a lot of standards about, we should be moving from basic descriptive research into experimental research, where we can actually see if there's a causal connection between the intervention that we are providing and the outcome. So there's both questions about the data we collect and then the design of the studies that we are encouraging in this area that I think we need some specific attention. But it is a unique field that poses some unique data and analytics challenges. So, for instance, there aren't a lot of areas of research in medicine where you actually need data that is external to the healthcare sector too. So if you're making referrals, you need to know what happened in that referral that happens outside of the purview of healthcare. And that is a new data challenge that the healthcare hasn't necessarily encountered or overcome in the past. You're seeing sort of new efforts towards data use agreements and business associates agreements where people can share data, but they're not yet the norm. And I think there are a lot of fears about data integration still. The technology question that you're asking is a little bit different. So we've seen this like huge new crop of tech tools, opportunities emerging in this space. They're really exciting. Most of them are platforms that are offering kind of synthesizing information about social services resources in communities. We haven't yet seen any really strong research demonstrating the added value of these platforms for improving social healthcare utilization. But I think that they're really promising. We just need to see the studies get done so that we really understand the impact of those major investments in this kind of rapidly evolving space. So those would be some of the themes that I would be inclined to highlight. I'm sure there are many more that Wanda and Rivka have in their back pocket too.
Wanda, Rivka, anything you want to add to what Laura said?
I'll chime in just from the federal perspective to hit on, I think, a theme that, Laura, you noted at the end of your comments on how much this is a burgeoning field of activity, and the research is very much lagging the activity here. I think I have had my eye on this from the federal perspective because, as I'm sure you are well aware, when there's a lot of activity in the space and many stakeholders, public, private, and otherwise are invested, folks see a federal role for trying to create some sense and order out of the chaos. And we have gotten more than one request or gentle nudge saying, maybe you all want to, create some standards a la AHC, which I know we're going to talk about, the Mental Health Communities model and its work here. Or maybe you want to create a centralized platform so that we aren't all buying our own versions of this and, letting the market dynamics play out. I'm not going to comment on us doing it here, but just to say, I think these are the types of dynamics that we are very attuned to, given how quickly the innovation is progressing in this space and how messy early stage innovation is.
Wanda, I think you might be on mute. We're not hearing you.
Sorry, can you hear me now? I'll add one more thing and share Laura's excitement and my honor being on this panel with these wonderful colleagues and friends. And the only other thing I would add to what was said here was that I think there's also a challenge in thinking through when you are able to think about like efficacy of something that a referral or something that was done. It's not always clear in the immediate aftermath what effectiveness actually means. So if you say, we referred someone to go get to make sure they got meals for their next few weeks, and that happened. In a sense, that's effective, but that's a short-term effectiveness, right? Because over time, have you actually fixed the fundamental problem? So I also do think that as we're evaluating, we need to be looking at what is sustainable, what is longitudinal, and not just necessarily immediate reaction. Because I think a lot of the early literature shows what happens with immediate fixes and not necessarily longer term upstream solutions.
Awesome. Well, thank you all for that. So takeaways, effectiveness research is important. We've got to figure that piece out. And then Laura, getting back to you, something else you said I thought was really interesting. The idea of we need data outside of healthcare. That's probably true, but one of the interesting things that we wrestle with is, are social needs, social determinants related to health? You know, can we define them as being health related as opposed to being outside of the healthcare sphere? So maybe I'll use that as a parry into, can you tell us about Siren, you know, and about sort of what you're doing to sort of increase capacity of evaluation around social determinant interventions?
Yeah, so Siren is, I like that you said that you affectionately refer to it as Siren. I do too. So Siren is a national research, translation, and acceleration institute. So we're essentially just trying to ensure that we learn from and share learnings from people around the country and now globe who are doing great work and great innovation in the social and medical care integration space. We do three basic things. We catalyze and conduct research. So we fund research. We do our own research. We also synthesize and disseminate research. And then we do a lot of consulting for governments and including the federal and the state level, and then individual healthcare organizations or researchers who are trying to study or apply the research to a program or policy that they are considering. So what that does is it also gives us a sort of unique vantage point to highlight some critical evidence gaps in this area. So we've produced a number of kind of syntheses describing what do we know and what do we not know. As an example, and I think we're going to talk about this a little bit more later, but we've seen really little scholarship actually examining the health equity impacts of social risk screening and interventions. Our implicit assumption is that addressing social risks and strengthening social assets is going to lead to improved health equity. But we haven't yet seen that research, in part because studies are small, they're not engaging diverse populations. There are lots of different reasons where we've actually looked at those outcomes. So this is where we need deep learning that is really focused on diverse populations that are big enough to see the differences across subgroups. We're trying to elevate that issue. We're writing about it. We're speaking about it. We're encouraging researchers to design studies that can help accelerate learning in that area. That's just one area. We're doing that in lots of different ways, including around kind of highlighting the fact that our tools, the existing screening tools, have kind of a vexing lack of consistency. So we're trying to help the field recognize and address the sort of problems with measurement, the problems with study design, and then the really fundamental issues that need studying right now that would help inform practitioners and policymakers.
Awesome. So that and that's a really good insight, right? So learnings only come when we have standards around data, and ultimately we have interoperability around the data. So let me double click onto that a little bit. So can you tell us about the Gravity Project, which is something that came out of Siren, right? That their mission is around innovation.
Yeah. So Gravity was an effort that we spurred through Siren, but we no longer are really spearheading it. So it really came out of our recognition that there was this surge of interest around social determinants related work in the healthcare sector, but very little ability to track that work using standardized medical vocabularies like ICD-10, SNOMED, LOIG, et cetera. The idea was that we would develop some national consensus on the terminology, the medical terminology that we would use for social determinants related screening, diagnosis, and interventions. And it grew. So we now have this incredible group of people who are running Gravity, including informaticists like Sarah DeSilvia at University of Vermont and Ellen Gallego at EMI Advisors, and an amazing team of collaborators and advisors from organizations around the country who are building that consensus around code development, which will enable us to aggregate data across lots of different institutions who may be doing slightly different things, but that data will be aggregatable. Is that a word? Hoping that's a word.
I think so. We coined it now. Mark it down. So that's awesome. So here's my last big question for you, and I'd love for others to weigh in on this as well. So assuming we standardize these data sets, we get some interoperability, and we have this data ecosystem, what are some best practices around how we actually measure the outcomes of these types of interventions?
Andrea, that is a great question. In some ways, I would just turn that right back on you. So your team.
I'm the moderator. That's not allowed.
No, but it's not fair. So the Bogle team has done some great work around, well, what's a meaningful outcome for Humana, as an example. And you guys have been pushing this healthy days outcome, the number of healthy days in the last month outcome, for instance. But without some agreement or some at least consistency, even if there's a core set of outcome measures, it really without that, we're really limited in terms of comparative effectiveness work. So I do think that we need some agreement about a core set of outcome measures that include social health, mental and physical health, and then some healthcare utilization outcomes, all of which are really important to our healthcare delivery systems and to our policymakers. In some cases, the other metrics will have to be more specific to select populations, but that doesn't preclude us from having some core set of common measures that are going to really teach us so much more about the effectiveness of these programs. I think that'll really help us in evaluation over time too. So those would be the kinds of things that I would say, gosh, wouldn't it be great if? Rivka, can you come that right away?
Yeah, I think you're right, though.
Yeah, well, I think, Laura, to your point, I feel like we are making some progress with Humana, so I joke a little bit. But to us, it's really about applying the same sort of rigor to social determinant kind of interventions and outcome measurement that we have in clinical interventions in the past. So it's thinking about leading indicators and midpoint indicators and lagging indicators. And so Healthy Days is a great leading indicator because it tells us how people are perceiving their own health. And then the midpoint ones tend to be clinical and quality type metrics. And then the lagging metrics are more about utilization, cost reduction, and things like that. So, I agree with you. And standardizing that certainly will help. Rivka, did you have some comments on that?
Well, I think I'll save them for when I talk more about AHD, because I'm just in hearing Laura describe what she sees as the evolution of the measurement work in this space and the sort of broader research work in this space. It really resonates when I think about what we were trying to do in AHD and where we are. So I'll save it for when it's my turn.
All right, fair enough. Wanda, anything you want to add?
I'm going to save it for a little bit later because I had a thought as Laura was talking, but I was thinking about some other measures that might be missing if we're moving from focusing purely on social determinant to more health equity. Some of the things that we're currently asking may not capture kind of the experience of patients. So when I think about maybe upstream a little bit more into structural determinants and things like racism and discrimination and poverty. Some of the measures that we have right now don't really get us to know anything about how that changes over time with interventions that we have. So I'll save my comments on that for a little bit later in the conversation. But it made me think about if we're going to move further upstream, that we probably need to think about measures a little bit differently.
Yes. Okay. Well, if you want to save it. We'll get back to it. But yeah, I really would love to dive into the idea of there are social needs, there are social determinants, and there are structural determinants. And it's a question of how far upstream and how do we define that and so forth. So, all right, we'll get back to you. So Rivka, why don't we'll move on to our next topic that you're going to be kind of our lead on, but again, I want everyone else to contribute. So next one is about how do we continue to drive innovation in the social determinant space? So going to lean on your CMMI experience here. And I guess to start, I'll start broad. So how do you think about leveraging policy change to do more innovation in the social determinant space?
Yeah, that's like the billion-dollar question, isn't it? We're really starting big here.
It is. Yeah. So sorry to put you on the spot.
I mean, I think in many ways, at least for me, in terms of thinking about the work that we can do at CMMI and the work that we can do in CMS in general here, just given how big of an untapped opportunity there is to really improve outcomes for patients, I think about the accountable health communities model, and it sort of centers me because it in many ways is a microcosm of what I see happening more broadly in this field, which is that when we set out to launch the accountable health communities model, there was very little work happening in CMS in the sort of social services, social needs, drivers of health space generally. This was going out on a limb for CMS at the time, and I think it's at this point basically public knowledge that it almost didn't happen because that's how out there it was. But it happened, and it's been, I think, in many ways, a tremendous learning opportunity for us and more broadly for the industry. When I think about what we set out to do in the accountable health communities model, I would say we set out to do two primary things. The first was to build capacity for organizations that were going to be at the forefront of this work, of identifying social need, of connecting beneficiaries to social services, and of building out a delivery infrastructure, both clinical and non-clinical, to really find and address these needs. That was the first thing, and I want to talk more about that. The second thing we set out to do was to build or contribute to the evidence base that I think Laura did such a great job of describing. And I've been thinking a lot about what we have been able to contribute to that evidence base and where we still have to learn when we think about where CMS and CMMI would go next on SDOH and related issues. So first, on the building capacity front, this is obviously a challenge because everything that CMMI does has to produce some sort of ROI or has to seem likely to produce an ROI. And capacity investments face an obvious challenge when you're thinking about everything from the perspective of its potential return. But one really encouraging place that I think we really bet on in launching AHC was that if we were able to connect beneficiaries to social services who presented social needs that were in some way healthcare utilization sensitive, we might be able to see a return on investment in the healthcare sector for addressing these needs in the social services sector. And the idea of spending money to build the capacity that we knew was lacking was a bet that I think has, to some extent, paid off. The first thing I would highlight was that when the AHC model started, basically all of the community-based organizations we were hearing from and that we continue to hear from and now work with through the model were really under-resourced. And so, we had to make a case for prioritizing resourcing these organizations from within the healthcare sector, given not just the sort of divide between healthcare and social services sectors historically and the prohibition on spending healthcare funds on the social services side, but also just competing priorities and other areas within the sort of traditional healthcare sector that were so poorly resourced. So there was a calculus, I think, on both sides of that issue. But in reflecting on where AHC has been able to make progress over the past 4 years, we have jump-started these efforts in about 30 communities to screen Medicare, Medicaid beneficiaries for social need, to connect them with social services, to navigate them, which also involves following up and getting a sense of how the work that happened at the beginning when we first identified these social needs has played out over time. And those efforts have really paid off. They've paid off in context of the model. We're starting to see some really promising early results on the Medicare side and are still waiting for Medicaid data. But I would argue that they have also paid off in amplifying and jumpstarting similar efforts outside of CMS, right? And I think Laura was alluding to this when she was talking about how quickly the innovation in this space has progressed. But there is so much investment here from certainly from government, but also from the research community, from payers like Humana that have incredible investments and have done incredible work here, and also just more broadly from the funders community, right, who is very invested here. And I think some of that is just because it was overdue, but I would argue that AHC has jump-started that and has fueled some of the momentum there by indicating, as with so many other CMMI models, hey, the federal government is here and we're prepared to participate in this effort, and in so signaling, we're encouraging the private sector to do so as well. So I think that's one place where we've seen progress. The data don't lie, and so we absolutely need data on what we're going to see from both Medicare and Medicaid sides to actually be able to say whether the model has done all of the different things that Laura was highlighting, and I think Wanda was highlighting too. So are we seeing immediate needs be resolved, but are we seeing potential downstream effects of those needs being resolved in terms of more stability for patients, for beneficiaries overall, and then potentially lower healthcare utilization and associated spending. So I think the jury is out on that. But we have seen, I would argue that we have seen those efforts to build capacity pay off in a number of ways. I think the second thing that we were really trying to do was build this evidence base. And that is where I think, just back to your question, Andrew, there's so much opportunity for us to continue investing and learning. Whether it's expanding efforts that are similar to AHC, or, just to come back to, I think, Laura's comments, really contributing to the efforts to standardize our approaches here, whether it's standardizing the approach to data we collect, standardizing approaches to how those data are used, we can talk about that more fully, but I think there is a ton of opportunity there. And I guess I would argue that CMS is big. They have a lot of programs here and therefore a lot of power. And so to the extent that we are invested in both creating and then using standardized data, processes, tools, et cetera, I think that could have a real impact.
Okay, that's awesome. There's a lot to unpack in there. Something I'm going to ask you a question that we didn't plan before, but you mentioned ROI. And I'm curious how you or CMMI sort of look at this, because by all accounts, I think AHC, as an example, has been really successful in creating capacity, right? And building an evidence base. And like you said, you spurred other work, you've created the data ecosystem, all these things that are arguably intangible, right? But traditionally, when we think of ROI, it's about hard dollars and cents, healthcare resource utilization reductions. But do you think more broadly about what ROI is? Like, creating that evidence base is valuable, right? And if you're addressing social needs and allowing people to access care, even if that's downstream, it stabilizes chronic conditions. Like, do you think more broadly about ROI?
Love that question. I love it so much. The answer, to speaking personally, is 100% yes. I run the prevention and population health portfolio. So if I didn't think about ROI more broadly, I'd have no work. But, in all seriousness, exactly. So I would say a couple of things. The first is, a question of where we're measuring the ROI. So if we're looking at ROI of healthcare work on healthcare utilization, there's sort of an obvious link. But once we start looking at ROI of social service provision on healthcare utilization, there's not, the link is more tenuous, and it's on us to really make that case. One thing that maybe I should just acknowledge is that while I am very inclined to look at ROI as expansively as possible, my actuaries are much less inclined to look at ROI in an expansive way. So we have an ongoing dialogue. Exactly. I was going to say, I'm sure you identify. So I think there's the question of sort of sectors, cross-sector ROI, and can we really count ROI over here towards the investments that we've made over there? But, the same thing is true when it comes to the work that we do in Medicare that might actually have a positive spillover effect for Medicaid beneficiaries, where we often can't even count that ROI, and it's within the healthcare sector. So, I think we have a fairly narrow definition of ROI statutorily, but have over the past 10 years been very creative in our model design in order to really broaden the ROI that we're investing to create as expansively as possible. So I think the question of sectors is one. I would also just note that there's a really important question, in many ways the question, about over what term we measure ROI. And I think that's particularly true here, right? Because social service provision can pay off in the long term. It's very much more challenging to have it evidently pay off in a 5-year performance period of a model. And so I think those are some of the more challenging questions that we have to confront in things like model design in this space.
Okay, awesome. Well, so my next question is, and you could use AHC or you could think about a different example, but like, what do you think are the best practices to get public-private partnerships, working with providers, kind of all those stakeholders involved in this kind of work?
I'll talk a little about AHC just because this is very much the moment we're living in right now. We have organizations that are doing incredible work that I think would like to see that work continue. We have a very active research effort underway to evaluate the model, but we have a separate, very active funders community that supports the model, provides technical assistance, and I think is really interested in how to scale these efforts going forward. So where do we go from here? You know, I think I hope, Andrew, that you'll have some discussion here, because I would really love to hear what Wanda and Laura think about what the next phase looks like. You know, I think to some extent the next phase is, how do we make efforts like this scalable for the organizations that are doing this work today? I think another big bucket in the sustainability category is, how do we make what is right now effectively optional become more compulsory? Whether it's raising the lowest common denominator of screening that's happening, finding ways to hardwire this into payer agreements. I mean, I'm really just throwing noodles at the wall. I hope that's apparent. But, you know, I think that is the roadmap, right, for taking work that is right now a pilot with roughly 30 organizations across the country and making it more scalable and sustainable.
Awesome. Well, yeah, so let's open it up. So, Wanda, I'll pitch this one to you. You know, this work increasingly involves working with community-based organizations, right? But sometimes they don't have the data, the technology, the tools and things to kind of engage with us. So how do you think, how should we be supporting CBOs in particular, but also providers?
Wow. Thank you for that. So earlier in our careers, Laura and I did some work looking at the impact of clinicians' level of confidence in the capacity of their organization to address social needs of their patients and clinician burnout. And I think most of you know about this work and the derivatives of this work. But what we found was that there was this very, very strong connection between places where clinicians, frontline clinicians who were taking care of patients largely in primary care settings, felt like they had the capacity in their environment to take care of, respond to patient social needs, and burnout. So if you felt like your clinic had a really good capacity to address those social needs, then you were much less likely to experience clinician burnout. And the converse was also true. And what that said to us was that, one, yes, we do need to equip and empower people to have capacity in their environment, so the clinical environment, to be able to do that work. But also, what happens when they start to ask those questions even more. So if you think about the network and the ecosystem that supports whatever happens after those questions are asked, first of all, talking about how do we screen for social needs and do that at the point of care and build that information into sustainable and structural systems that will allow us to do that efficiently and consistently across all domains, that's a whole different topic. But let's assume that we've done that. And then all of a sudden we have screened and we've identified challenges for our populations of patients, and then we want to now connect with community-based organizations that are doing really good work to address those issues. They also need the capacity building that the clinicians need to be able to be prepared for, you know, the influx of folks and services and decisions that are needed to be made to support what we find. So I think that a really important thing, as we're thinking about, like, from the clinical delivery system, like, how do we build capacity? We've also got to think about simultaneously how do we build capacity for the folks that are doing the work in the community, because they will be responding to what we find out. The other thing I think about is, and Rivka, I was thinking about this as you were speaking. You know, how do we to incentivize people to actually care, right? So, like, we've done a lot of good work in incentivizing screening. We can build in some way that we can push data in front of clinicians and they can see it and they can respond. But what we find a lot of times is people do see social risk and social needs data, and there's not a response that is generated by that, because when they don't know what to do, and where will they take that information. And so I think linking those community-based organizations, as some of the work that you're leading, Andrew, I think is really important in making sure that it's not just, I know that the risk is here, but it's what can I do immediately in that step at that point of care to respond to it. But, thinking about how do we also start to incentivize not just that we did screen, not just that we did refer, but that there was a change in the ultimate health outcomes, and that we saw something, and that, as we're shifting towards more value, like how do we incentivize that an action being taken, an outcome being achieved? And I think that's where it gets a little bit trickier, but that's where I think the community-based organizations that support some of the work that we're doing could be really, really powerful, because if they have this opportunity to have visibility over this life cycle after someone kind of leaves the clinical space, figuring out how do we help them to be able to build capacity to follow and track, I think is a really good opportunity for us.
That's great. A lot of good stuff there. Laura, same question to you, but I might ask you your perspective on how state Medicaid agencies can innovate. So what are the best practices there, or the levers that they can pull?
You're going to have to hold me down, Andrew. I have so many thoughts, and state Medicaid agencies are just one part of them. But Rivka and Wanda have elevated so many great points. So okay, I'll start with state Medicaid agencies. But I got stuff I want to share. I'm so excited. So first, I say I 100% agree with Rivka's point that this, in some ways, the value of the HC demonstration model is signaling, hey, see, the federal government is saying that this is important. And what we have seen, I thought the snowball coming down the hill about social determinants was already pretty big, but dang, it got bigger. It's so big now, and it feels like you're being crushed all the time. Like I look up and I'm like, help, like let's run faster, further. The snowball is so big. And that is both exciting and terrifying, right? Because sometimes the snowball's so big and you're like, wait, why is there a snowball there? It's summer, whatever. So I just think we need to, in some ways, as a researcher, I just want to say, slow down, like let's figure out what works and how it works and why. But one of the effects of that signaling of interest has been that state Medicaid agencies across the United States are now increasingly, they see the writing on the wall. They say, oh, the feds are really interested in this. Something's happening. We're interested in it too. We know we have this massive priority around health equity. And we think that in intervening, understanding and social context and intervening on social context is going to be really important. CMMI has developed one demonstration model related to that, but we want to innovate in this area too. And we have seen an enormous range of innovations from state Medicaid agencies in the last 5 years since the Accountable Health Communities demonstration launched. So that has ranged dramatically. Like there are people who are just focusing on social risk screening, and that's where we've seen some of the quality measurement work focus. But there are also agencies that are really trying to move away from solely screening with the goal of saying, oh, we want to do the resource connecting, or we want to stimulate much more sort of alignment work, so community level investment. And they are using their procurement contracts. We've mentioned this, but just as like spaghetti on the wall, it's not just spaghetti. It's like really happening, right? So there are a lot of different levers that state Medicaid agencies, I think, are experimenting with. The challenge that we have is that we haven't necessarily built a shared learning community to sort of look at, well, does this work better than this one? And how did you get that through your contracts, your contracts negotiations, or how are you using performance measures? And this is where I want to emphasize just one other maybe useful framework for folks who are listening in today. So, in the work that we did with the National Academy of Medicine around developing a kind of typology of different kinds of social care work that the healthcare sector could be engaging in, we didn't only focus on social risk assessment and referrals or assistance. We also talked about the other kinds of activities that healthcare stakeholders should be thinking about when they are designing their social care programs. And the reason why I want to emphasize this is I think that we've actually had a disproportionate focus only on screening and then assistance. Like you ask about it, you have to have a response to this. But what we hear from patients actually is they just want their providers to know. They want their providers to understand that this kind of conversation is really going to affect relationships and trust, which is so fundamental to ultimately to healthcare outcomes, to adherence to treatment recommendations, right? So, and that there are things that healthcare systems could do, even in the absence of the opportunities to refer or resources in the community. There are things that we can do even within the context of traditional care, in addition to relationship building and trust building and validating, that social situation is going to make this hard for this patient. There are things that we can do, like an example I like to use that's super evidence-based is we could adjust insulin doses based on for patients who are experiencing both diabetes and food insecurity, because patients who are in that situation are much more likely to be hospitalized at the end of the month when their food benefits run out. So for us not to take that information about food insecurity into account when we are prescribing insulin is bad care. And there are a zillion examples like that. So I just want to make sure that as a group, we're thinking not only about the referrals model that is the AHC model, but all the other things that we could be doing to make sure that we're not doing more harm in healthcare delivery than we are doing good for patients who are coming from a range of different backgrounds. So all of that to say that I think that the patient experience of care outcomes that Wanda was referring to, and the rationale for collecting this information is much broader than just the Accountable Health Communities demonstration. And I think we're seeing that play out in some of the state Medicaid agency quality measures and other levers that they're using. Okay, phew, I'm done. I have more.
Awesome. Yeah. So that was a barrage of imagery there. We've got snowballs crushing us and spaghetti on the walls. We've got data and referrals. And I mean, there's a lot going on there, a lot that we could spend hours and hours talking about. But, one of the sort of underlying threads throughout all of that is this idea that healthcare and social needs are not distributed equtably. There's this sort of thread of inequity underneath there. And so I'd really love to pivot to our third and final topic. And Wanda, this is coming to you first, but I want feedback from everybody. But what is the role of health disparities or health equity or let's get back to your structural determinants of health. Is that really where we need to start if we're going to achieve and leverage all the leverage that Laura just spoke about?
Yeah. I feel like running on a treadmill after Laura talks. Like I feel like I got to go do something more exciting than sitting down at a chair. So it's so great to hear from both of you. So many things are spinning through my mind. But I guess the first thing I'll say is how could we not focus on health equity? I don't understand how we could not. So we've got loads and loads of data that tells us that we've got poor clinical outcomes and health outcomes, but also if that doesn't speak to you from a kind of clinical health outcome perspective, then the financial implications of health inequity are pretty staggering as well. I mean, we know that we're spending billions of dollars in extra medical care, lost productivity, just because of health inequities. And so I think about there's not an option for us to continue and allow the kind of inequity that we've seen to be real. So I think about a few things as I think about addressing some of these challenges. First of all, we have to fundamentally believe that every single person in our nation, in our world, honestly, but in our nation, if we're speaking from a U.S. lens, has an opportunity, deserves the right to the highest quality of care, the fullest and best health, and a right to live and experience life without discrimination or oppression. And we have to actually fundamentally believe that. And if we don't, then we won't do anything, right? We have to fundamentally believe that. We have to believe that if I'm living in a zip code where we have high indicators, we have good schools and education, we have low crime, And, a few zip codes away, that is not the reality for our neighbors. We have to believe that that is not right, that's like fundamentally not a good system and a sustainable system. So I think we have to believe that. But I was thinking as we were talking, what if we started to actually codify what we know about the impact of things like racism or gender discrimination or poverty on people's actual experiences. Like, we know that, racism itself leads to a lot of toxic stress, and we know that it leads to earlier heart disease, and there are a number of things that we know. What if we started to ask people, kind of like the healthy days that your team has been working on for so long, Andrew, like, what if we started to ask, like, a racism-free day or, an oppression-free day? Like, how has your experience been, and how is your health better because we have eliminated some of these structural determinants? And I would love to see how we started to reframe some of what we ask people about their experience to not just kind of the social things, but the structural things that impact them. And that would mean we'd have to do a lot of things. We'd have to figure out how we included health and a health equity focus in every single policy. I mean, transportation, commerce, aviation, banking, and every other policy that we have would have to have a square focus on health equity, because we know that so many of the structures that lead to health inequities are from industries that are not necessarily related to health. So I think we'd have to be really purposeful and intentional about doing that. We'd also have to really think about how do we disaggregate data. And it seems to me pretty surprising that still right now, like in 2021, that we still struggle with actually believing that we should look at data and look at different segments of our population so that we can be responsive to their needs. So I think, Andrew, we have to believe that health equity is an important goal, and we have to collectively want to achieve it. We have to believe that the status quo is not acceptable, and it's killing people, and it's ruining communities, and it's devastating lives, and it's blunting futures for people. We have to believe that. And then we have to believe that we also need to find better ways to ask about some of the structural challenges that we don't necessarily have built into any one system. I think we're good. We're getting really, really good at asking about some of the social needs, but we have to get better at some of the structural things so that we can also devise solutions around those and really make those connections for people between the impact of some of those more oppressive structures on their health.
So that's really powerful. And let me double click on that a little bit, because I think you did a really nice job of explaining what health equity is or disparities. But how do we go about going to measure? Because I feel like you've got to benchmark something, have a baseline so that you can set targets and figure out what to address. But is it about asking questions like healthy days about, how many, oppression-free days did you have in the last month? Or do we start with that data disaggregation that you mentioned? And if we do that, how are we defining? What are we disaggregating? Is it really about race and ethnicity? Is it about gender? Is it LGBTQ plus status? Is it all of the above? Sort of where do we start and how do we define our terminology?
Yeah, I'll say yes. So I think your question was also, I think all of the above. I mean, we know that people experience life in very different ways, and the intersectionality of people's identities has a lot to do with what their experience is. So I think that your gender identity, your racial identity, your ethnic identity, your religious identity, your geographic location, all those things actually come to it. You can't really ask someone to take any of those pieces away from them. So it does become complicated when you think about, is this the gender piece that's driving this inequity, or is it the race, or is it the religion? And so I think that is an important thing to think about. But I do think that we have to start with even just kind of knowing on a basic level, like the race, ethnicity, language, sexual orientation, gender identity. Those ones are ones I think we have definitions for, we can actually start to unpack. But I also think that we do need to think beyond immediately. I mean, I think we should continue our work. And I think, as Laura said, the snowball is getting bigger. It's exciting to see the momentum around social determinants, social needs, and social drivers. But also, I think we're now realizing that there's a new frontier. And I think that is where we leverage what we've learned already about social and start to think about what is the way you ask about structural. Because if you don't, I mean, if you, and as I was saying earlier, if we respond to food by food insecurity or food challenges by giving food, right? Like, I think that is phenomenal, and it resolves a very important challenge that people are experiencing, absolutely. But if we don't respond to food deserts and why certain communities are deprived of healthy options and things like that, then we can keep providing all the food that we want, but the experience and the structures that are around someone are still going to kind of draw them back into those challenges as soon as it becomes possible, as soon as that food runs out, or as Laura was saying, as soon as that food benefit runs out, we'll start to see some of the adverse effects on health outcomes. So my charge is going to start thinking about what are those measures. I can't say that I've got a good measure in mind. I'm thinking of oppression-free days and racism-free days. Are we moving the needle not just on what you're experiencing socially, but what the structural environment around you is doing? And those are the kind of things that I think that we need to be thinking about. I hope that helps.
That's yeah, absolutely. That's really helpful.
More questions than I am answers. So.
No, I'm writing them down because we got to talk offline about those. Rivka, I might ask the next question to you, and similar to some previous ones, but sort of what's your perspective on how government, industry can sort of work together to drive awareness around disparities and inequities, and work together on policy change and solutions?
I'm so happy that Wanda shared her perspective on how we should be measuring health equity, even though it was just, super drafty and brainstormy, because if you think about the full spectrum of ways that disparities and inequity inform our lives as Americans to just as people, I think Wanda is talking all the way at the patient-centered end of the spectrum, which is, what does this feel like for me? I'm not a person who accesses healthcare. I'm just a person, and my life experience is going to inform everything about me. And so ask questions about what my life experiences are on a day-to-day basis and how I'm experiencing inequities, structural racism, other things that are probably having downstream effects. CMS is on the whole other end of the spectrum, right? But I don't think that that's necessarily bad. I think, in fact, it's very important, even if it's just a starting place. So to be specific, we have been asking questions internally about where there are disparities in our work, including things like whether we have algorithmic bias in how we set benchmarks, including things like whether there are disparities in who participates in our models, and in whether we have fewer participants or fewer of the eligible people who are actually participating in underserved communities. And I think these are, they're just at the very other end of the spectrum from what is my lived experience as a person who also gets healthcare. But I think they're a really important starting place for us to understand the impact that our footprint has on equity. And, we can only go in one of two directions. We can either reduce disparities or we can increase them. And I think on a very fundamental level, it is our job to make sure we're not increasing disparities. And I think much of the work that we're doing now in terms of internal examination of our set of programs can reduce disparities over time.
Awesome. Thanks for that. Laura, I want to ask you a question. I think we're going to have to make this the last one because we're running long on time. But what do you think, from your perspective of Siren or Gravity, what's the role that equity plays in kind of the nuts and bolts of how we implement social determinant strategies?
I'm trying to think of a good metaphor just to be consistent with my other answers, but I can't think of one. Snowball, spaghetti, something else, hamburger. I don't know. So I think the research in this space has not helped us yet. I think there's some really important ethics and equity questions around the integration of social and medical care that we need to attend to. The urgency is there. People are demanding the research. The moral imperative is there. There are so many reasons that, for all the reasons that Wanda just pointed out, that we need to pay more attention, and that spans the whole National Academy of Medicine framework. So how do we think about awareness? What does the experience of screening feel like for people who have really good reason to distrust the healthcare system, who every day experience discrimination and racism? What does it mean to combine data, even if we're not asking patients in person? What does it mean to combine data that patients don't have access to or don't even know on the back end, right? So if we're, there are big health systems that are pulling in bankruptcy history, education history, incarceration history from big consumer databases, and patients don't even know that that's happening. What? Like how is that ethically okay? And how does that perpetuate our, as Rivka was pointing out, our algorithmic biases or our inherent, the discrimination that is built into our system? The same can be applied to assistance interventions. I really appreciated Rivka's point that now they're doing an analysis of like, who are the participants in our models? Who are the people who are actually willing to participate, able to participate, targeted for participation? There's some really important questions about assistance models. The same is true for adjustment. How do we ensure that any changes that we make to our healthcare delivery plans, like treatment recommendations, et cetera, are not rationalizing poor care for particular populations? That is a moral imperative. We have done that before and done poorly. Right? We have systematically done poorly by Black people, other people of color in the United States, and we have earned their distrust. And we need to make sure that we are doing more and doing differently and doing better in the future. And then certainly for all of the sort of framework things that are the National Academy of Framework elements, categories that are about the way that we work in our communities, healthcare systems cannot be the leaders here. We need to be listening to the voices of community stakeholders and following, and, being really good allies and partners in order to change the structural determinants that Wando is highlighting. So I would say, this is part of our research agenda moving forward, and of course our practice agenda. But hopefully we will learn from our practice. I hope that was directed enough. But basically, all I want to say is yes to Wando and Rivka. Yes.
Awesome. I love that. Thank you. We are going to have to end there. I'm sorry to say that because I feel like we could talk for hours about all this and go deeper into it. But I want to thank all three of you for joining this discussion. It was rich. We went in depth on a number of topics. The whole idea was to talk about the future of population health and social determinants. And I think, we did that. Mission accomplished. We are going to figure out the data infrastructure and the interoperability. We are going to continue to innovate. We are going to address inequities. We're going to achieve equity. So Laura, Rivka, Wando, thank you all so much for joining me in this panel today. Really appreciate it. And everyone out there, have a great afternoon.
Thank you.
Thanks, everyone. Great job, Andrew.